Thank you, Dr. Chow. Good morning, everyone. So I'll be going over interatrial septum review as well as atrial septal defects. So in terms of the objectives, I'll briefly review the embryology and anatomy. I'll go over some of the common atrial septal defects, echocardiographic techniques for assessment and indications for intervention, as well as post-intervention assessment and some possible complications to look for on echo. And I'll go over a few cases at the end as well. So most of the content, as well as some of the videos and images, I've taken from the 2015 ASD guidelines. And then there are some other sources that I'll mention as I go. And the cases are from the patients that we have seen in the echo lab here. So essentially, interatrial septum, the atrial septal communications are about 6 to 10% of congenital heart defects. The incidence in live births is about 1 in 1,500, and the atrial septal defects are the most common acyanotic congenital lesions with 1 in 1,000 live birth incidence. So in terms of embryology, I'll keep it brief and try to make it as applicable as possible. But essentially, the atria develop as a common cavity. At around 28 days of gestation, septum primum starts forming, and it comes down from the roof and starts migrating towards the endocardial cushions, as you can see in the image here. And then septum secundum, which is an infolding of the atrial roof and not actually a true membranous structure, starts developing, and it's usually to the right of the septum primum. And that's important because the interplay of these structures and the defects in them are essentially the main discussion of the talk today. And the ostium primum, which is closed by the fusion of the mesenchymal cells, is one of the communications between the two atria. This diagram is a little bit better in terms of looking at the embryology. So the ostium secundum, the terminology can be a little bit confusing, develops in septum primum, and that's covered by the septum secundum. So it's shown in this top figure over here. Then the foramen ovale that I'll briefly touch on later as well is kind of a persistent orifice that forms between these structures, and it's persistent in the septum secundum. And you can see in this figure here, the red is essentially the septum primum, the blue is the septum secundum, and the foramen ovale is shown in the cross section. So in terms of anatomy, there are several components to the atrial septum, as I mentioned, primum, secundum, and the atrioventricular canal septum. And depending on where a defect might happen, we can get various types of ASDs that I'll discuss, but this is a nice figure that shows some of them, like the SVC type, sinus venosus defect, IVC type, ostium primum, ostium secundum, and their relation to the other structures in the heart. And lastly, sinus venosus is adjacent to the septum and atrial communications, and it's also nicely shown in this diagram here, where it might develop, and again, in relation to the SVC or IVC, which has two types that I'll touch on later. So just briefly, in terms of clinical manifestations, there is the type of pathophysiology that might develop from ASDs is right-sided volume overload in isolated ASDs, as the blood essentially flows from left to right into the eventually the pulmonary circulation back to the left side. patients with ASD can develop significant shunt flow. I won't go over shunt assessment in detail, but generally a ratio of pulmonary flow to systemic flow more than 1.5 is thought to be significant. And usually they become symptomatic. If they just have an isolated ASD, they may become symptomatic by their 40s. But this is a general ballpark number, and it can vary based on several other characteristics. Common symptoms that patients can complain about before they're diagnosed could be exercise intolerance, fatigue, dyspnea. In some cases, they may even present with heart failure. Atrial fibrillation is the most common atrial arrhythmia, but other arrhythmias like supraventricular tachycardias, atrial flutter can also develop in these patients. And in terms of the natural history, there is quite a broad range of how these patients can present. So they may have spontaneous closure that can, for example, happen in small ASDs, about 40% of them, usually in children. But if the ASD size is more than 8 millimeters and it's discovered in adults, it's less likely that it's going to spontaneously close. Other things like asymptomatic RV enlargement, consistent with that right-sided overload, and dyspnea and heart failure that I mentioned could also develop. So I'll start talking about some of the specific types of ASDs. So the most common is OSTIUM secundum ASD. It happens in about 70 to 75% of the patients. It can have various size and shapes, and it essentially is a deficiency in the septum primum tissue. It can have, there are various margins. So the superior and posterior margin is composed of the septum secundum. The anterior margin is usually the atrioventricular canal septum, and the inferior margin is usually the septum primum and the left venous valve of the IVC. And this 3D reconstruction shows some of the common types or common shapes. Could be round or oval, small or large, for example, just to give you an idea. There are 4 anatomic variations depending on the size of the OSTIUM secundum ASD. So they could be complete absence of the septum primum tissue. They could be deficiency, but the septum primum is still present. There can be fenestrated septum primum, so there can be multiple ASDs, and the fenestrations in a very deficient septum primum as well. These are important considerations in terms of echo and assessment, and also in terms of device closure down the road, because it will dictate what type of device can be used, how many devices might be required. The OSTIUM secundum ASDs are prone to getting larger over time, whereas the patients age and with cardiac growth, and they're amenable to percutaneous transcatheter closure, which I'll go over the indications and some of the devices later on. So this is a T by cable view of a secundum ASD. I hope it's playing well. I have put a case at the end that I'll go over as well. I just want to show this here. And this is another T by cable view. Here, as I mentioned, there could be fenestrations or multiple ASDs. So this is the case where we can see at least 2 jets or 2 ASDs in this case. So the next one is OSTIUM primum ASD. As you can see, the frequency is much smaller, about 15 to 20%. It's usually an atrioventricular canal defect. In this case, the epicardial cushions fail to fuse, and there's abnormal migration of the mesenchymal cells. There's a common association with ventricular valve anomalies, and again, that's important when these patients are being assessed with echocardiogram. They can be, for example, a cleft in the anterior mitral valve leaflet. They could be bridging leaflets that straddle from the RV to the LV. The borders of the septum primum are generally the septum primum ASD is septum primum superiorly and posteriorly, and then the common atrioventricular valve annulus anteriorly. Generally, because these defects involve the atrioventricular valve orifice and margin, there is not enough space for a percutaneous transcatheter device to be placed, and these defects are not amenable to this kind of closure. It was difficult to find a good video of this, but this is an image from the guidelines that I think the nice thing about it is that they show the defect here and the common AV valve, and kind of you can see the close association with atrioventricular valves in this case. Next one is sinus venosus defect. It occurs about 5 to 10% of the time. It is technically not a true ASD, and there is partial and complete absence of the sinus venosus septum. The SVC type, so there is two different types, as I mentioned earlier. It could be an SVC type or IVC type, and the sinus venosus septum absence or deficiency can be between can be closer to the SVC and the right upper pulmonary vein, and there can be a right upper pulmonary vein anomalous drainage associated with this. So it can, for example, drain into the right atrium, which happens in most of the cases, or it can connect to the SVC superior to the right atrium. The other subtype is an IVC type, where there is anomalous drainage of the right lower and middle pulmonary veins and the right atrium. Again, this type of defect is not amenable to device closure due to kind of the poor anatomic structures and some of the rim characteristics that I'll describe later on. In this case, it's a TT subcostal view, and they're showing the SVC type of the sinus venosus defect. And then I have another video after where it's looking at the IVC type. And again, it becomes important to interrogate the pulmonary veins because if surgical closure is needed or additional interventions, it's important to know what type of anomalous drainage is associated with this defect. And then coronary sinus defects. So it's basically an unroofing of the coronary sinus. That's the other terminology that's very commonly used. It is quite rare, maybe about 1% of atrial communications. It's also not technically a true ASD. And the wall of the coronary sinus in the left atrium is usually deficient or absent. And again, this type of defect is not amenable to percutaneous device closures. Generally, they may be considered in some specific cases. That's beyond the scope of this talk. And here it's moving in and out a little bit, but this was one of the better examples of TT subcostal view that I could find showing the unroofing of the coronary sinus. So I'll touch on PFOs. They can be a separate topic on their own. They're again not a true not a true deficiency of the atrial septal tissue, but I think it's quite common to confuse PFOs and ASDs, and I just wanted to go over a little bit of definition and anatomy on this topic as well. So they are quite common. They can happen in 20 to 25% of adult patients. And PFO is that potential space or separation between the septum primum and septum secundum. And the two-dimensional views are a little bit difficult to illustrate this. I'll go over some echo images as well. But they can essentially be stretching of the membranes that allows the PFO to open, or there can be variations in pressure that allow that communication to open up. But it's generally the potential space, as opposed to the ASD, where there was deficiency in the tissue or a clear ostium or communication between the right and left atrium. And PFOs generally remain functionally closed if the left atrial pressure is more than the right atrial pressure, and there can be transient increase in the right-sided pressures that cause the the flow from right to left. So I think the yellow arrow clearly shows where the PFO is in this case, and the TE, and you can kind of see the flow that is shown with Doppler on this image. But I think in the next video should be a little bit clearer. So in this case here, so that's kind of what I had for going over the anatomy and embryology of the atrial septal defects and some of the other common defects that are not that are generally associated with ASDs. So I'll go over echo evaluation, and generally TTE is used as initial evaluation. There is various advantages and disadvantages with the different echo modalities. I won't be touching on intercardiac echocardiograms and intraprocedural echo, as again that would be kind of beyond the scope of this talk. But generally with the TTE, we can get a good initial assessment. There is limitations in especially adult patients, and kind of trying to have a good look and interrogation of the septum with a transducer. And so other modalities like a TEE are used if there's clinical suspicion or need for further characterization of the abnormalities. Also, in cases of SECUNDUM ASDs where transcatheter closure needs to be planned, a TEE is required. And TEs can help define the margins of the ASD. They can look at the surrounding structures. They can find out if there is additional defects associated with the ASD as well. And then 3D echo, which I have a few images here and there, is also very helpful in determining the size and shape of the ASD and to delineate the rims of the surrounding tissue. And it gives a good kind of three-dimensional understanding of the relationships of all these structures. So the guidelines have a few nice summary tables where, for example, TTE that we're all familiar with, they go over the advantages and disadvantages. Again, the things to highlight on this table, I won't be going over the entire text, is that in the interatrial septum, the lower rim is generally not well seen after device placement due to shadowing. So if there is concern about either residual shunt or erosion or other things, TTE is not great for interrogating that. And TEE, again, as I mentioned, it's great for planning and for characterizing the defect and the surrounding structures. And I think we're all familiar with kind of the general disadvantages, sedation, risk of aspiration, and those kind of things. The other table that I just wanted to briefly highlight was the various views on TTE and TEE that the guidelines provide. And the nice thing about this one is that it clearly identifies which characteristics or which dimensions, for example, can be assessed on which views. And the images are not great, but for example, on the subxiphoid view, assessment of the SVC, IVC can be done. The atrial septal defect diameter sometimes can be measured. And on the four chamber view, looking at the rim of the defect of the atrioventricular valves, possibility for an assessment of the RV dilation, as we know. And kind of the similarly for personal short axis view, it's good if we're looking at those aortic and posterior wall, posterior atrial wall rims. With the TEE, they again provide various angles, the different views for looking at the defects. And again, what I found helpful here was in the basal transverse view, looking at the right upper pulmonary vein, which again can have anomalous drainage in SVC type sinus defect, or kind of looking at the 4-chamber views and looking at the atriovesicular rims. And again, the short axis view, if there's a device, they can look at the relationship to aortic valve and the postural atrial wall. And in the bicable view, which I've shown some images earlier, they can look at the IVC and SVC rims. So I'll go ahead with some of the more details on characteristics of ASD. So essentially, there's various types and associated defects that I mentioned. Generally, we want to look at the Doppler flow, so whether it's left to right, which is very common, right to left, whether it's transient or if it's a late stage presentation and it's persistently right to left, or if it's bidirectional. And then there is presence of other associated structures like atrial septal aneurysms, eustachian valve, or Chiari network. And the size of the ASD, the minimum maximum diameters and areas, location of the septum, measurement of all the rims, shape, and any dynamic variability. So whether the minimum maximum areas change with systole and diastole. And for secondum ASDs specifically, because they're generally amenable to device closure, length of 5 millimeter or more is considered favorable for each specific rim. If the terminology is deficient rim length, if it's less than 5 millimeters, and in that case, some of the devices are not are contraindicated. And there are generally 6 rims that I'll just briefly mention. So aortic rim, atrioventricular valve rim, SVC, IVC, posterior wall, and right upper pulmonary vein. And so the guidelines highlight the importance of measuring each rim individually, again, in order for interventional planning to go ahead effectively. Next, in terms of interatrial septal imaging, this is something I learned here as well in TTEs, that the maximal jet, the maximal width of the jet on the color flow can correlate with direct surgical measurement of the defect, but the guidelines are very cautious about using this measurement on its own, as there can be many issues with relying on this for planning. So they do emphasize the importance of using other 2D or 3D measurements without color Doppler to confirm the measurement, especially if it's being used for surgical planning. And then just briefly in terms of assessment of the shunting, I mentioned direction of the shunt flow. The color scale generally needs to be set to assess for lower velocity of the shunt flow. So generally 25 to 40 centimeter per second is what the guidelines are have recommended. And then I mentioned about the direction of flow as well. And then in terms of the most pronounced echo finding associated with left to right shunt is that dilation of the RV due to volume overload. And the QP to QS ratio, which, as I mentioned, more than 1.5 to 1 is considered significant. So, sorry, I'm not sure if there is any issues with the meeting. It's just okay. It's fine. Sorry about that. So the 2015 ASC guidelines have mentioned indications and contraindications for closure. This is based on the 2008 AHA/ACC recommendations for adults with congenital heart disease. So I've mentioned their old kind of table of recommendations here, but then I also have the updated guidelines based on the 2018 AHA/ACC recommendations. So generally, the indications for closure in the old guidelines was isolated secundum ASD with pulmonary systemic flow, systemic flow of more than 1.5, and signs of right ventricular overload. And then in terms of PFOs, cryptogenic stroke and evidence of right to left shunting. In terms of the contraindications, so if the shunt flow was not significant, if there was a single defect that was too large for closure, if the defect was too close to other vital structures like the SVC, IVC, and if there was severe pulmonary hypertension, bidirectional flow, or kind of Eisenmenger's type physiology. And then I'll go over, like I mentioned, the 2018 guidelines, which are somewhat more updated, and the recommendations are a little bit more specific. So this is, I've skipped over the diagnosis part, and this is specifically about the intervention. So similarly, they say that adults with isolated secundum ASD causing impaired functional capacity, which I mentioned some of the symptoms earlier, right-sided overloads, that's the right atrial ventricular enlargement, and kind of evidence that there is net left-to-right shunt that's large enough to cause that physiology without cyanosis at rest or during exercise is the recommendation. And so there's a bit of a difference between the American guidelines and the European guidelines. So here they have mentioned some cutoffs for systolic pulmonary artery pressure less than 50% of the systolic systemic pressure, and kind of the pulmonary vascular resistance is less than 1/3 of the systemic vascular resistance. The European guidelines actually provide some specific cutoffs for the pulmonary vascular resistance in terms of Woods units that would be appropriate or inappropriate for intervention. And then kind of another class 1 indication, similarly would be adults with significant shunts, right-sided overload, who also have functional impairment, and they have, I think here they've tried to capture those main features, but then also want to try to exclude things similar to Eisenmenger's or any significant pulmonary hypertension as well. In terms of their kind of class 2A indications, so if the adult patients are asymptomatic with isolated secundum ASD, and the net shunting is still significant, but they're, for example, going for other surgical interventions, it can be considered that the ASD can be closed. These guidelines don't specifically mention paradoxical emboli and cryptogenic stroke, but they are covered in the European guidelines as well. And then I just want to touch on the kind of contraindication. So ASD closure should not be performed in adults with pulmonary artery systolic pressure greater than 2/3 of the systemic, pulmonary vascular resistance greater than 2/3 of the systemic, or net right to left shunt. And this is consistent with what was kind of in the previous or older version of the guidelines. And they have this in terms of an algorithm for secundum ASD, because there's options for surgical and device closure. They've tried to cover both. So if the shunt direction is left to right, that's followed usually by the hemodynamic assessment. Even though echocardiography is validated for using for assessing the shunt flow, generally an invasive assessment is considered. And based on that, they look at the functional impairment, and then that kind of provides you with the level of evidence and classification for recommendations of surgical or device closure if they're functionally impaired, if they meet all the hemodynamic requirements as well. And if not, you kind of follow those previous recommendations for any other kind of class 2A or class 2B indications for closure. in terms of evidence for this, there is really no clear or good quality randomized controlled trials that I could find, but there is a publication from the 2018 assessment of interventional therapies versus medical therapies for secondum ASDs. And they did a pooled analysis of multiple studies, several cohort studies, and they did not have enough evidence to comment on mortality improvement in adults with ASD repair, but they were able to demonstrate that it has shown functional status improvement, reduction in RV size and RV function, and I just highlighted one of the figures here that they have for improved odds ratio for NYHA1 before and after ASD closure, as you can see with the diamond that's shown here. I'll briefly touch on the types of devices. So two general device types have been approved by the US FDA. The first one is the Atrial Septal occluder, ASO. It's a double disc mesh and polyester fabric, and it kind of goes on the two sides of the atrial septum with the goal of creating a space where tissue can grow in and seal the defect. And because it has kind of a narrow neck, it can be useful for those ASDs that have fenestrations or multiple defects, and appropriate devices of appropriate sizes can be selected for each defect and placed during the intervention. And then the second one is the cardioform septal occluder. It's kind of a double disc design. This is what it looks like when it has not been deployed, and it also kind of serves a similar function. And because it's soft, it may be slightly more maneuverable when they're trying to close a defect. Just one slide here on ASD in pregnancy, and it's a topic that I think I haven't found a lot of great evidence around. Most of the case series or reviews were back from the 70s, 80s, 90s, but generally it's thought that young women with a small uncomplicated ASD, generally less than 5 millimeters, tolerate them well during pregnancies and even multiple pregnancies. This is interesting because with pregnancy, we know that the cardiac output increases, stroke volume increases, but a simple or a small non-complicated ASD is not known to cause major complications by itself. There are there are increased risks with secondum ASDs if they've had history of atrial arrhythmia, specifically atrial fib or flutter, or previous history of right ventricular failure. But then if the ASD is repaired and there's successful closure with minimal or no significant residual shunt, again, the risk of hemodynamic complications or paradoxical emboli decrease significantly during pregnancy. And so now just touching on device complications, as this is something that we'll have to be aware of when these patients are being followed up with echo. The risk of device embolization is about 0.1 to 0.4% of the cases. The risk of erosion is about 0.1 to 0.3% of the cases. And device erosion can occur kind of at the roof of the right atrium or the left atrium. There's no clear understanding of the exact etiology, but it's thought to be kind of as a result of the shear forces, the mechanical forces between the device and the myocardium, and especially during the initial stage where there is inflammation of the myocardium. For device embolization, the patients can present with various symptoms. They generally happen in the acute stage. For erosion, they can be kind of in the acute or subacute stage. They can be a little bit more non-specific in terms of their symptoms. They can have chest pain, shortness of breath, they can have syncope, they can have sudden death. And generally, things to look for on echocardiogram would be any pericardial effusion, tamponade, aortic fistulas, and again, like I mentioned, generally up to 72 hours, but there have been cases that are reported up to over 6 years later. So the guidelines provided another summary table for device complications. I'm not going to go over everything, but I think for assessment, generally, a TTE can be done. Yeah, of course. So yeah, I'll go over 3 cases just to give us time for a bit of discussion. So the first one is a case of a 74-year-old gentleman with NYG3 symptoms who was discovered to have an OSTIUM SECUNDUM ASD with left to right shunting, and when he developed atrial fibrillation, he had severe tricuspid regurgitation and got very symptomatic. He had a quite significant shunt flow of 3.2, and then he received an ASD closure with an Oculotech device that resulted in symptom improvement. And I've shown a photo of that here. Again, it's kind of similar to the device I showed earlier with a 2-disc kind of assembly that has that can allow for a tissue growth in between and kind of seals the 2 sides of the atrial septum. So this was, I think, one of the nicer images on the initial assessment of his TEE that showed a 1.8 by 1.4 centimeter OSTIUM secundum. You can see it in the 3D reconstruction. And then this is his TTE assessment following device closure. And we can kind of see where the device was placed in the interatrial septum. And then this is just another assessment to see if there is any residual shunt, and there doesn't seem to be anything significant here. So the second case is a sinus venosus defect. This was a 51-year-old gentleman with dilated right ventricle, atypical chest pain. He was found to have SVC type sinus venosus defect. It was 1 centimeter, and he had an anomalous right upper pulmonary vein draining into the SVC. Again, significant shunt flow of 1.8. As I mentioned earlier, this type of defect is not amenable to device closure, so he had a kind of a 2-patch technique with surgical repair. And they found one of the kind of nice images that shows the defect in this case on his initial echo with T. I couldn't, unfortunately, because some of the studies were old, I couldn't find a good follow-up echo because the studies were difficult to get. But I'll just finish off with this last case of a gentleman with unfortunate story of bilateral cerebral stroke who was found to have a PFO. On the TEE, there was left to right shunting at baseline, but there was kind of transient right to left shunting with snoring. So this is his PFO that was assessed with TEE at baseline, and it's I'm not sure the pointer is visible, but it's very clearly seen in the middle of the screen. And this, and if you kind of wait for it, you can see the reverse direction of shunting in this case with snoring. So I'll just finish off with a few key points. So PFOs are not a true deficiency of the atrial septal tissue. They're defined by the demonstration of right to left shunting, by contrast or color Doppler. OSTIUM secundum ASDs are the most common deficiency in septum primum. They can be various sizes or shapes. They're amenable to device closure. OSTIUM primum ASD is failure of fusion of the endocardial cushions, not amenable to device closure. Sinus venosus and coronary sinus defects are, again, not true ASDs, not amenable to device closure, but there are other associated septal defects that are important to be aware of. And especially with sinus venosus defects, it's important to remember that they're SVC, IVC types. They can be associated with those pulmonary vein anomalies, and that's something to look for. And then just kind of to wrap it up around the echo assessment for post-device placement. With the Atrial Septal occluders, we look for device position, any residual shunt, any evidence of complications, and that's usually done before hospital discharge and then following 1 week based on the guidelines. And then if there's presence of pericardial effusion, that could be a sign that there may be device erosion already, even if it's kind of a small or moderate size effusion. And then generally follow-up echo is recommended at 1, 6, 12 months, and then after that every 1 to 2 years. The main thing there, again, to look at is device stability and any other features of complications that may happen later on. So that's all I have for the presentation. Sorry about the technical difficulties in the middle. I'll just stop there if there are any questions.
So once again, thank you, Hirmand, for your wonderful presentation, very comprehensive. And I think anyone who is on the phone, next time when you actually take a call, please don't put us on hold and just hang up, and then we go from there. So that's probably the reason. We'll try to figure a way to mute the phones. Just a couple of interesting observations. So just to comment on Eisenmenger disease is actually different than Eisenmenger syndrome. Eisenmenger disease is originally described by Victor Eisenmenger in the 1800s from Germany, describing a young man with ventricular septal defect with right to left shunt. And then Eisenmenger disease, Eisenmenger syndrome is actually described by a Canadian women physician from McGill, who was a student from William Osler, and who described any hole in the heart or congenital heart disease that has the reversal of this shunt. So Eisenmenger syndrome is actually described by a Canadian women physician. So that's something that we should be proud of. And the other observation is Kurt Emblatzer. Who is Kurt Emblatzer? Or who's Emblatzer? So it's actually Kurt Emblatzer, who is an Austrian radiologist and an inventor. He unfortunately died in 2019 at age 95, but he's most famous for the Emblatzer closure device. So those are my eponyms for you for today. And on a separate observation, I noticed that on your presentation, you mentioned the PFO prevalence can be up to 20 to 25%, which is very high. It's 1 in 5 to 1 in 4 of the studies. So it depends on where you find the report. We have seen it anywhere between 1% to 9% to up to about 20%, as you have said. It depends on how you find them. So I think on an echo point of view, with color Doppler is probably less than 1%. With agitated saline contrast, if you do in everyone, which we don't, it could be up to 1 to 2%. But then if you go all the way up to using a patents of like postmortem type of a situation where you stick a probe in, it can be anywhere. Like usually the Mayo, there was one large Mayo series that described up to 9%. So 20 to 25 seems very high. So just an observation. So any other questions? Comments from other colleagues? Oh, there's someone in the chat. Let's see what they say. I see. Kim Connie. Oh, okay. So thank you for joining. And any other comments? There's one that says silly questions. I'm trying to find that. Oh, it says here. From Dr. Kumar, it says here, maybe a silly questions. When you do decide a PFO is, or when do you decide a PFO is not an ASD? So Hirmand, back to you. So how do you tell a PFO from an ASD?
So that's a good question. I think, again, depends on your mode of assessment, but if you're looking at it with an echocardiogram, I think some of the videos, maybe I can bring them up. If you see that clear space where shunting can happen, but there is no clear defect in the membranes that causes a direct communication. I think you can call it PFO. And that's kind of what I would say.
Yeah, this is a one question actually I asked myself at the end of my cardiology training, and I sort of learned that as I begin as a echo fellow. So from a transthoracic point of view, anything that is smaller than 5 millimeters that is discovered by the color Doppler, you can't tell. So it can be a PFO, it can be a small atrial septal defect. That's usually what we say. Anything that is like the color jet or width is more than 5 millimeters tend not to be PFO unless it's really eccentric, but you will see that. But anything more than 5 on transthoracic tends to be more likely to be an atrial septal defect. So that's one. On the T is much more obvious. On the T, what we're looking for is that a PFO is like when you have a jacket, right? So left over right, or right over left, depends on whether men or women. You have a slit in between that goes over between the two slits, right? But when you have an atrial septal defect, especially for circumambient ASD, it's actually a hole in the primum ASD, which is a very important point because it comes up in the exam all the time. It's like, where's the hole of the atrial septal defect? And then you have a multiple choice. The answer is actually a hole in the septum primum. So yes, to answer Dr. Kumar's question is how we tell it usually, either on transthoracic or transesophageal. Excellent questions. Any other questions? Okay, maybe while we're waiting for question, I want to welcome, this week we got another 20 subscribers, namely some colleagues actually signed on as a group. It's from the Cambridge Memorial. So thank you very much. And right now we have 200 subscribers to these rounds, and we're broadcasting all over Ontario. So, and also some of our former Echo Fellows are actually watching that from Saudi Arabia. So reaching out far and wide. So, and these rounds are helpful to smaller labs maybe, and where, you know, it's hard to organize these rounds on a regular basis without a substantial number of colleagues who can give these rounds. Otherwise, you just keep going back to 1 or 2 persons. So once again, any other questions? Last call.
Jiming, it's Bob.
Hi, Bob.
Hi, maybe a little discussion about the issue of the rim on transesophageal echo, and when is not enough rim and how many segments a contraindication to a percutaneous closure device?
This one may be harder for Hirmand to answer. I'll let you go have a go at first. I'll tell you what we think.
Yeah, so I'll go back to that slide that I had. I think generally less than 5 millimeters. I know for the rim length, especially I think with the Amplatzer device, that's generally considered a contraindication. But having said that, I was going through some of the cases that had device closures here, and in one of them that I presented, I think the rib length was actually 4 millimeters on one side. So I'm not sure how clear cut that 5 millimeter cutoff is and how much room we may have. That's kind of the extent of what I know.
Yeah, we can confirm with the interventional colleague. From my understanding, from Dr. Chisholm and other colleagues who does atrial septal defect device closure, 5 millimeter is what we usually go by when we do the TE. We try to map them all out, like you said. But usually the aortic side, they can tolerate a slightly less, because the thing once it goes in is like a Pac-Man. So you look at the TE picture, especially the older Amplatzer device, it's like a Pac-Man that goes, you know, around there. So they can tolerate a slightly smaller rim on the aortic side, but everything else, you know, is more than 5. That seems to be my answer to this question. It seems to be what we hear from the interventionalist. Excellent. Okay, so let's see. Now it's 8:07. So once again, thank you for this very comprehensive review, and we'll post this online for people to look at, because it's useful, you know, to come back to these things. Especially we now have a series of holes in the heart, both in the atrial level and also ventricular level. So thank you very much, and have a wonderful day to everyone.